It's an agonizing wait that can mean the difference between life and death. Being on the list for an organ transplant. A study out of UMass Memorial Medical Center in Worcester revealed that a growing number of usable organs are never finding their way into an operating room. Between 2007 and 12, 4,300 patients were removed from the waiting list. That's an 86% jump from the 2,300 patients who were denied in the 5 years prior. Joining me to explain how something like this can happen are Dr. Adele Bazorgade, a transplant surgeon from UMass, who along with his colleague Natasha Dolgen co-authored the study. Good to meet you both. We're also joined by Glenn Cohen from the Petrie-Flum Center for Health Policy, Biotechnology, and Bioethics at Harvard Law School. It's great to see you. So, Doctor, if you can, what did your research conclude was the reason for so many people being dropped from this transplant list?
Sure. So in essence, the CMS, in order to regulate the practice of transplantation in the United States.
This is Medicare and Medicaid.
Medicare and Medicaid. In 2007, instituted a regulation named Condition of Participation. This regulation was intended to standardize the quality of care across the board for all transplant centers and benchmark the outcome. However, the unintended consequence of this rather restrictive and punitive action pushed the transplant centers to care to a large extent about their outcome and be watchful and fearful of how their outcome is affected.
Because in part, the ratings that would result might affect Medicare funding and that sort of thing. So what was happening is they're throwing out organs that, although not perfect, were usable. Is that correct?
So actually, this paper focused not on the organs, but the patients themselves.
What does that mean?
So there's a separate process for selection of organs versus selection of patients. So when a patient with liver disease or kidney disease comes to a transplant center, they're evaluated as potential candidates. So if they're able to tolerate a surgery and if they're able to benefit from that surgery. So once it's concluded that they would benefit, they're added to the waiting list, right? So we looked at the people on the waiting list, not the organ offers.
And what did you learn about the people on the waiting list?
So essentially what happened was that after this policy went into place, the rate of people being removed for being too sick to transplant started to really rise pretty rapidly.
Even though, for those who are lay people like me, the whole notion is the sicker you are, you're supposed to be higher on the list.
Exactly.
Here, the sicker you are, the more likely to be dumped from the list because it's going to affect your rating, which means it affects your Medicare money?
So I have to say that the interpretation is that it's likely concern over the rating, but in this paper we really looked at the observation that this policy occurred and had a statistically significant effect on the trend.
Based on reading
but I'll say that this is a trend in a lot of kind of these sorts of consumerist attempts to measure things that you end up seeing gaming by the centers, whether it's cardiac bypass reporting in New York or other recommendations.
You know, most people think, I know it's wrong, technically the Hippocratic Oath doesn't say first do no harm, but essentially says that. How does this fit first do no harm? If you're really sick, you should be at the top of the list. If you have an organ, maybe that's imperfect but usable, by my standards, it's pretty much better than a certainty of dying, isn't it?
Well, your sickness is a complicated factor, right? So, for example, the distribution of organs has different rules for livers versus kidneys. For livers, being sick is very important for being high up on the list. For kidneys, urgency is less important. And really, we're trying to balance several principles. Sick is first, but also best outcomes.
But can I get to this whole, even though Natasha was saying that wasn't part of the research, this discarding of organs, my notion on this, and I'm not an ethicist, has always been, if someone is pretty certain to die, and there's an alternative that would make it less likely they die, as long as you fully disclose what your odds are and your risks are, then let the patient with his or her doctor make a decision. How is it ethical to comply with whatever this rating system is, just be tossing these organs? I don't get this.
Yeah, so again, their study doesn't show any evidence of tossing the organs, but it does happen, right? And one of the interesting issues that comes up as a doctor is how you communicate what the risks really are to a patient. But if you're talking absolutely a patient who's about to die, giving them a chance with a bad organ or no chance, I'm completely with you.
You know, this is sort of the bad news part of this, but my understanding is once your study came out, people in Washington actually got a little bit of religion, and there's a little more leeway, even though maybe not as much. So in English, I guess, what exactly are the changes and how do they benefit real people?
Well, The changes perhaps aren't enough to have a meaningful impact on this practice altogether. I think the importance of this study is to refocus and shine light on this very important issue, on this very important subject. The intention, you see, as a practicing surgeon, I can tell you that you have a patient, just like you said, who has pretty significant risk of dying within the next few days.
Without a transplant.
Without a transplant. And then their chances of dying is perhaps in excess of 85%. But then on the other hand, with all the knowledge that you have in your disposal, you can predict that if I use this particular organ for this patient has a 70% chances of survival. And let's say that 80% chances of dying versus 70% chances of survival. The whole understanding here is that a lot of centers would pull back and would rather not take that risk because of that risk effect.
I don't know if you spoke to any of the practitioners here, but it seems to me if I was what you are and what you want to be, if I was under these kind of constraints, it probably cause me to choose another profession. I'm serious. Do we have any idea how people are supposed to make people healthier react to these limitations?
So the thing is that quality initiatives are supposed to be, a positive thing. It's not that we don't want to improve the quality. It's just about having a balance and having an informed quality policy. So in this case, the policy only looked at post-operative outcomes. It didn't consider the waitlist outcomes, so there's no balance. In other cases, there's a lot of CMS policies beyond the transplant world where it's pushing practitioners to practice in a certain direction consciously or not.
I don't know if this is in your bailiwick here, but where does the blame lie in this? When I'm reading this stuff, I'm saying, is it the federal government or are the hospitals that basically should be challenging? Where does the blame lie?
So I think the answer is both. And again, the road to hell is paved with good intentions. When they passed this regulation, it was to improve quality. It had a good intention, but it's had this perverse outcome. If they don't change it, knowing the perverse outcome, that's when I really lay the blame.
And by the way, if they change it, it's going to be because of you people. So thank you. It's a pleasure. Good to see you. Congratulations and thank you.
Before I say good night, I would like to acknowledge the donors and their families that are the true heroes in this effort, saving lives every day. And I think that as a society, we owe them a debt of gratitude for their selfless sacrifice of choosing to be donors.
Thank you so much. Good to see you as well. Appreciate all of you.